Hello, it's Dr. Lewerenz here at Longevity Health Institute. I'm going to bring you some of the study recaps here. I've done this before and talked about some journals and things that I read and research and look at. And these are fun and exciting because they're more of an allopathic traditional approach. In fact, actually looking at a recent, in the last 6 months or so, New England Journal of Medicine, and then New England Journal of Medicine Journal Watch, in studies and articles, and then how I kind of incorporate these, and I want to give you my take on them in a integrative approach and real evidence of new things kind of going on. Okay, one thing that I want to share with you though, because I got a message about, you hear me talk about adrenal dysfunction and adrenal fatigue, and here's a book I picked up, The Diseases of Adrenal Dysfunction. One thing I want to share with you here is from 1936. In 1937, these doctors, Myers, Mason, and Kendall here, in this book that smells like it's 100 years old, it's kind of about 80 years old, but they talk here about adrenal insufficiency, hypoadrenalism, as well as Addison's disease, which is basically not making cortisol or adrenal hormone. And here we deal with chronic fatigue and chronic adrenal things. But even in this book from the 30s and 40s, they talk about and really start to suggest, because of finding the adrenal cortex and the hormones that are associated and made from the adrenal cortex, their purpose. And what's really interesting, even back then, they have no evidence, and they say we can't really speak of fatigue or adrenal insufficiency, okay, again, 80 years ago almost, okay, but they do say that there is common symptoms, and you've heard me say in other videos about chronic fatigue, and that is fatigue, hypotension, which is low blood pressure, dizziness, and that, and there's things you can do with salt tests and that for that, but also weight gain. And then I'll tell you, lethargy is also mentioned there. But fatigue, dizzy and lightheaded, and hypotensive, and weight gain. Very common, and that's in that book. But anyway, let's talk about some new journals, new articles. So this was published again. It was put in an abstract here with the New England Journal of Medicine Journal Watch. And actually, this one here is volume 41, number 15, and actually came out at August of this year. And this was actually pulled from publication of Natural Academy of Science USA 2021, June 8th. And it's called Bacteriophages Are Correlated with Human Diseases. Now, what does this mean? But basically in this, and I will read you quote for quote, but you hear me talk about the gut health and gut microbiome, right? How important your gut flora is, and how in preventing chronic disease, supporting your immune system, having less inflammation, and yes, weight loss. In fact, it's one of our 4 points in our model for weight loss and weight reduction and weight stability is you have to have a good gut, you have to have good microbiome. So here, nearly 2,000 phage pathogens DNA sequences were associated with human chronic diseases, particularly Parkinson's disease, okay? And they go on to say that commensal gut bacteria were first linked to obesity and weight gain in 2006 in the New England Journal of Medicine, published in the General Medicine, January 15, New England Journal of Medicine, okay? And then also in 2007 in Nature Journal, medical journals, okay? That gut microbiome is associated with obesity. Here they're saying it's also associated with Parkinson's, but also how important it is. Over 2,000 species were identified in your bacteria of your gut flora, okay? And imbalances there with chronic diseases, okay? So, what does this mean? Well, this is something in a traditional journal just this August coming out that suggests that, hey, you have a good diet, you have a good digestive lining, and you have buildup of good gut flora. One of my primary home run hitters is making sure that you're on a good probiotic and having a good whole food plant-based diet, and mostly, and I will tell you that you will have less chronic disease with aging. And here we look at aging as a disease, You don't want to be behind that 8 ball with aging and have some chronic conditions develop. So I have several journals here, and several articles I wanted to bring up. Due to time, I'm just going to hit some big ones. But again, once again here, publication, another topic, but another publication, American Journal of Medicine, 2021, June, okay? Reproduced here in New England Journal of Medicine, Journal Watch, okay? But malignancy is the most common cause of severe eosinophilia in northeastern U.S. study. What is severe eosinophilia? Well, very simple. You get a blood test. We do them here all the time. When you have high eosinophils, I don't mean borderline, but severe eosinophils, we have to think of immune responses, autoimmune responses. Like I mentioned in this previous article, gut health, your immune system. So we look at markers like this. We look at metrics and we track these. But severe eosinophilia, okay, is linked to, in this study, severe eosinophilia, 39% of cases, okay, diagnosed with organ malignancies. So you can't discount that even without symptoms. We got to dive deeper in looking at what is going on. Is there a sign that you have some immune issue, some organ issue? Is there a cancer going on? We have to look into this. Now, what I see here often with eosinophilia is I have to look at gut health and your esophagus and eosinophils in your esophagus and something called EOE, which is eosinophilic esophagitis, which is very common in pre-malignancy of the esophagus and gut. Okay, so very, very important here. But also remember, severe eosinophilia, if you're out there, you know people that have been told your eosinophils are high. Yes, a little bit high, can be related to allergies and many other things, but excuse me, but severe eosinophilia, high numbers repeated in many studies, okay, lab tests done by your doctor, your provider, could suggest a cancer, okay? Not good. Got to dive deep on that and look into that, okay? So let's go here to another New England Journal of Medicine publication. Again, this was one that was published, give me a second here, the British Medical Journal, 2020, July 14th, okay? And it is Statins for Primary Cardiovascular Disease Prevention, a new meta-analysis. So basically, do statins work in primary prevention for cardiovascular heart attacks and strokes? And this has always been debatable, okay? Here you hear me talk about statins and cholesterol a little differently because we look at you as a whole and we try to fix you and get you in balance, okay? And not look at cholesterol and that is a disease because there's benefits to cholesterol. But again, here it's saying, and you know, I'm not going to refute this meta-analysis that says that in primary prevention, there are benefits. There's risk reduction, okay? And this was looking at roughly 10,000 patients. Excuse me, I'm sorry, I'm going to restate that. It was a meta-analysis of 62 randomized trials, which they used statins in over 120,000 patients, okay? And there was a significant absolute risk reduction of about 15 per 100,000. Not much, but also, you know, it was statistically significant. But here's my problem. My problem is this. In the own journal, it says, of note, statins have been associated with a small excessive risk of diabetes in use in secondary prevention trials, okay? Now, what does that mean? Well, if we're not looking at you as a whole and you're getting a statin because the evidence of, hey, in primary prevention, everybody should be on these with high cholesterol, you could be leading to later diabetes, and you could be leading later to Alzheimer's or studies on that. And, you know, decades and decades of statin use, and somebody's got low risks, you got to talk to your doctor, you got to talk to your cardiologist, your provider, talk to us here at the office, and we'll guide you best with good intention and evidence. But, you know, this is where I have a problem, and it's in a journal that is actually staying it, and it states it at the end, which is kind of ironic, kind of buries it a bit, okay? Found this one kind of funny. It's not too medically related, but physician attire doesn't matter to the patient. Hopefully you like my suits. Occasionally I do wear a white coat, but I try to look sharp, you know, I try to keep it together. But does it matter if I wear a white coat? According to this, it does. I should be wearing a white coat. You actually would respect me more, and patients like their doctors in a white coat. Found that kind of tongue-in-cheek, a little bit of ironic. But anyway, So another great one here. This is in, again, New England Journal of Medicine, Journal Watch, okay? This is a publication in July, again, okay? July this year. And let me get to it, but it had to do with COVID-19 and long-term COVID symptoms, okay? And evidence of this. And nearly, and you've heard me say this before, and again, this was published in JAMA, in our medical journal here in May, and then republished in this abstract. But nearly 3/4 of patients reported at least one persistent symptom after a mean follow-up of 3 months after having COVID-19. And the most common symptom was shortness of breath, fatigue, anxiety, cough, and to the least degree, depression, which was 15%. But more than 40% of people reported fatigue at 3 months, okay? And more than 36% of people presented with shortness of breath. Now, anxiety and malaise and kind of maybe brain foggy, amnesia, they call it, and that was about 25-30%. Point being is almost nearly a third or more people are having significant symptoms 3 months out, okay? I've seen other studies about this status post-COVID-19 that is really significant, related to 6 months out, at least one symptom. So, that's very relevant. I see that here clinically, sometimes even worse. The big thing is inflammation and the cardiovascular effects from microembolization and thrombotic, meaning your blood gets thickened and blood circulation. What do we learn in med school day one? You have to have good oxygen and good circulation. A, B's, and C's. Airway, breathing, circulation. If these aren't good, nothing's good. And that's what COVID-19's hitting with the virus and with the inflammatory reaction in that, okay? So we have a protocol here. Come see us, email us, as a patient or new patient. My providers and I will all bring you the biggest toolbox to help you in an integrative recovery approach very successfully with a long haul or post COVID-19, okay? But that's happening. It's now. And by the way, if your symptoms are minimal, don't discount them. I see high D-dimers, blood tests. I see infections that are lasting. I see cognitive tests that we have objectively, our EEG tests, that people have low voltage. This is real stuff going on with infections and post-vaccine, etc., that have a lot to do with the virus and long hauling. Recoveries could be long. Who knows what's going to happen here on severe cases. Now, one last article, same thing, New England Journal of Medicine, okay? And this was published in April 2021, but methylprednisone is better than dexamethasone in severe COVID-19. So I can tell you 100%, early on I was using more dexamethasone and as a steroid, as an anti-inflammatory, and we're seeing 3 to 10 COVID-19 patients a day here. Telemedicine, obviously, and doing our best integrative approach to help them, with their immune system and whatever intervention they need, the best guidance. But ever since we've switched using methylprednisone, we have seen better results. And I want to tell you this, is that it was pretty significant. In fact, hospitalizations and mortality were about a 15% difference with the use of the different type of steroid. So definitely getting the methylprednisone tends to be looking a lot better as far as an anti-inflammatory when you have COVID-19. My best advice to you is prevention, and good hand washing, protection. We use a lot of silver, Argentine 23 and nanoparticle silver, antiviral, zinc, quercetin, D, vitamin C, NAC, and talk to your doctor. And don't wait a week till you're severe. Talk to me within a day or 2 or 3, okay, so that you can get the right treatment and the most effective and the most efficient, and not behind the 8 ball, if you will. So again, I love these journals. I love these articles. Again, published in a respectable a medical journal that's been out literally since 1812, the New England Journal of Medicine. And I just like to give you my little twist because I'm always looking at journals like Townsend Letter and Holistic Alternative Medicine and traditional articles and kind of putting these together for you, because there's nothing bad about allopathic and if you will, traditional approaches. And just like you have to use common sense about, holistic natural approaches, but these can bring you the best of both worlds in a personalized functional model to regenerate, recover, and optimize things for you with the best intention, doing no harm, okay, but making you thrive, not just survive. So hopefully that was entertaining. Hope you like the suit better than the white coat. And come see us, check in, follow us on Facebook, on YouTube, on Instagram. Me and my providers bring you the best in functional, personalized medicine. Be well.